Good morning, everyone. We're going to get started in about 1 minute, so if you could just get settled, grab your coffee, top up. How's everyone feeling this morning? Are we still at a 10? That band was so amazing yesterday. Okay, we're in the home stretch. This is the final day of the conference. What I'd like to do is actually call up our amazing opera singer to introduce our next speaker. Giorgio, thank you for last night. That was unbelievable. Your voice is incredible, so thank you very, very much. Come on up.
Good morning, everybody. I'm not gonna sing. Don't be afraid. It's an honor for me to introduce the first speaker today, because it's an extraordinary experience and that happened in a country that only a few years ago they didn't know the syndrome. And this is what I keep saying since I joined IPWSO long ago, that parents move the mountains. And I don't want to add anything more to the story they will tell you, but this couple is wonderful. And I just want to say that we have been lucky as IPWSO that we met this first couple, this first family, where both parents are professionals, because Loisel is a doctor, pneumologist, and Marlene is a psychologist specialized in special education. The best combination to have a son, or they have a daughter with Prader-Willi syndrome. And this is the way we started. And things are improving so well. But I leave them the stage, and please enjoy. Thank you very much. Loisel and Marlene.
Good morning again, and let's start with our presentation. Our presentation is about past, present, and future of Cuban families with children affected by Prader-Willi syndrome. Taiwan marked the beginning of a new stage for all Cuban families because it made possible that our reality began to change.
For this reason, we marked 3 stages in the timeline: past before 2010, present from 2010 and now, and future from 2017 on. There was no multidisciplinary consultation in Cuba. There was a lack of literature on this topic. Family with children affected by Prader-Willi syndrome did not know each other. They thought they were alone in the world.
After a modest research with the support of the Madrid Association for PWS, now PWS Foundation, IPWSO, Cuban Caritas, our health and educational national system, we contacted a small group of persons diagnosed with this syndrome. This workshop was a significant event because, for first time in Cuba, 6 families and some professionals met for first time to discuss and to know more about PWS. This workshop was supported by Ciego de Ávila, Cuba.
After 2 years of intensive work, fulfilling this objective as a Cuban family for Prader-Willi syndrome, The second workshop of our group was held in Havana. Thanks to the generosity of 12 foreign specialists introduced by IPWSO through Giorgio, we organized the second workshop on of Cuban families with children affected by Prader-Willi syndrome, with the live participation of a local and event foreign parent who came from Spain, Italy, Dominican Republic, and Guatemala. In this slide, we can see Fernando and Mariana from Spain, Giorgio and Irene from Italy, our dear Dr. Mori from USA, Julia Bonelli from Dominican Republic, Luis and Mayra from Guatemala, and our dear Fanny from Chile. They were in charge of developing the whole scientific program. They gave all of their information for free. It's a good experience, a big experience for us families. We could obtain information for free.
In that workshop, the topic Prader-Willi syndrome appeared in the program Learning to Grow by Cuban Caritas. After fulfilling this objective, our group was more organized and strengthened. With the support of the Madrid Association for PWS, Cuban Caritas, Rome Caritas, and IPWSO, we could organize for first time in Cuba in October 2013, the first national meeting for families with children with PWS, to give them the possibility to know each other and share.
Do you know who he is? 22 people with PWS from 4 to 34 years old participated with their families in a national meeting. There were 80 people involved, families and volunteers. The 18% of the family met for the first time other family with children affected by the same syndrome. Health, education, and sport professional helped us as volunteers to take care of each person with PWS. The volunteers were prepared and had experience how to manage this syndrome.
We traveled 12 hours by car. We arrived to Guantanamo very tired, but it was worthwhile because we gave information and orientation to sports, health, and education professional to work with 3 children and their families. We also preparing professionals coming from other provinces, Santiago de Cuba, Holguín, Las Tunas, and Granma. More than 160 masters in genetics and clinical genetics from all Cuban provinces participated in this event. We presented our experience about neurocognitive rehabilitation. The National Cuban Human Genetics Group and the Cuban Society of Human Genetics engaged themselves in changing the PWS reality in Cuba.
This is our outcome from this 6 year. We have developed workshops, lectures, postgraduate courses that brought us to very positive results. We identify 8 families in 5 provinces. We use provinces, I think for you it's state. For 6 years, Marlene and I worked voluntarily for this project. We identified 8 families in 5 provinces, and there were 20 professionals that know how to manage the syndrome. We have to work long hours during weekends and holidays, and our free time. 6 years later, we have identified 50 families in all Cuban provinces, and there are more than 200 professionals who know how to manage the syndrome. 6 years later. I went on to cry. We have family and professional contacts in each province.
Prader-Willi syndrome is a known disease found in a subfield in our country. At this moment, we only have the FISH technique to confirm a clinical diagnosis using the criteria of Dr. Holm to identify new cases in Cuba. IPWSO, PWS Foundation, and Cuban Caritas are like a great family for us. We couldn't achieve such impressive result without the precious and continuous support of these institutions.
Light come to our family with a free diagnosis made by birth in Italy in 2009. We began to get information from IPWSO Foundation in Madrid and the IPWSO through Channel and Sergio. So we adapted it to our context. It's very important for us to adapt it to our context because our context is different, so different of the rest of the world. So we adapted it to our context. We began to work with our daughter. After 7 years of intensive work, we have some visible results. I will like to say thank you to IPSO and to Foundation for Prader-Willi Research Canada to give this opportunity to share our modest experience with all of you. And to finish, I would like to show a video showing the result of 12 days of training our daughter how to dance. It's a present from our daughter to us. So, and we want to share it with all of you.
let me add something more. Today is a special day for Marlene and Loisel. It's their first presentation outside Cuba. And we are so proud and happy as IPSO that we could make this dream come true. But it's a special day today. It's their wedding anniversary, 15 years ago.
So I don't know if you saw this beautiful couple dancing last night to Bailando. Raise your hand if you saw them dancing. They lit up the dance floor, so now I can see it's a complete family thing. Great job. That was beautiful. I love Cuba. I've been several times, and hopefully one day I can go again. Hint, hint. So I just want to explain a little kerfuffle in the schedule, and it was totally my fault, so I apologize. But if you look at the mental health behavior panel, I have listed a number of names. And I think in our field, in PWS, we have so many mental health experts. And I asked Tony Holland to join this session, and then I asked Jan and Linda to join it, and Tony Holland's name was removed from the agenda by accident, and that was not my intention. So Jan and Linda will be speaking later. They have several sessions throughout the afternoon that are amazing. I highly recommend you attend them all. But I would like to call up Tony Holland to chair this session along with the others that are listed in that panel to continue this. I think yesterday was a great example of how a panel discussion can bring up a lot of questions, so we do want this session to kind of replicate what we saw yesterday in the diet session, where there's presentations of expertise in their area related to anxiety, behavior, mental health, but then really have a lot of opportunity to ask questions to these experts and share things within the audience, because I know a lot of you in this room have a lot of experience, and sometimes parents become experts over the years. So please don't be shy, enjoy your experience, share your experiences, ask questions, and please welcome Tony Holland to the stage.
Thank you very much, Tanya, and really pleased that we have, an hour and a half for this session. As Tanya said, the idea is that we'll have some brief presentations at the beginning, but really plenty of time for questions and answers. And we really want to hear you talk about how you have struggled and perhaps learnt to manage some of the difficulties that you have experienced. So I've been asked to chair this session. So I'm a psychiatrist. I work in Cambridge in the UK. I'm a patron of the UK Prader-Willi Syndrome Association, and also chair the Clinical and Scientific Advisory Board of IPWSO. And I've worked both in the capacity as a clinician and as a researcher in the field of Prader-Willi syndrome for many years now, and have learnt so much from coming to these meetings, and everyone like this one is just wonderful, and it's a real pleasure to be here. So to set the scene a little more, the presentations are going to be from Hubert Sawyer from Germany, Elizabeth Roof from the USA, and Kate Woodcock from the UK. And then after the presentations, and each of those will be relatively brief, there'll be the opportunity for questions and answers. And Linda and Janice will also join us at that point. But as pointed out, they're also speaking later, and I highly recommend their talks. They're two people with immense experience working in this field and helping families and people with Prader-Willi syndrome. So I'm sure you'll find those sessions really informative. I do want to just set the scene a little bit for the presentations and for the discussions, because I think sometimes there's confusion. We use sort of different words like mental health, challenging behavior, problem behaviors, and so on. And then in among all of that, there's the overeating or the hyperphagia. I think the approach to all of those, both from the point of view of trying to understand them better through research, but also in clinical practice, is best encapsulated by what is sometimes seen as a bit of a cliche, but I actually think is really important here, and that is referred to as the biopsychosocial model. What it's about, particularly I think in Prader-Willi syndrome, is asking oneself to what extent are these mental health and problem behaviors that are observed best understood in terms of something about the biology of Prader-Willi syndrome, something about the way the brain has developed and how the person responds to various challenges in their lives. But clearly, there's also a very strong, if you like, psychological component in the sense that behaviors do not arise in no context. They are shaped and reinforced and triggered by the way others have responded both in the past and in the present. And also there are very good psychological models that have been derived over many years within the field of intellectual disability more generally that helps us understand why such behaviors might occur. And then, of course, there's the social perspective. There's the environment that the person lives in. Is it a well-structured, full, dynamic environment, or is it rather empty with lacking structure or any shape to it? The environment clearly is going to be important, and I think that the presentations will help to reflect that, and I'm sure this will come up during the discussions. The environment may help determine the likelihood of a particular behavior arising or not. It may not eliminate it, but it certainly helps to diminish the risks of such behaviors. So what do we know in terms of some of these biological factors? Oh, I think the other point that I should have made too, the other component to all of this is the developmental component. We all know how children develop and grow and acquire new skills from childhood through to adolescence and into adult life. So there is this component in Prader-Willi syndrome about to what extent is the developmental profile of people with Prader-Willi syndrome atypical? Is it delayed? Is it different in some way or not? And that again can be very important in the way that we understand some of the risks for behavior problems. So, well, what do we know? I think from the point of view of research in many countries in the world over many years now, we do know that there are certain problems, and you will know this very well, better than anyone. There are certain problems that seem to occur in excess in people with Prader-Willi syndrome. It's not that other people with developmental disabilities don't also have them, but they seem to be a particular problem for people with Prader-Willi syndrome. And from a research point of view, we need to understand why that is. So these include not only the hyperphagia, which is so familiar to all of us, that emerges from this early period of undereating, but also things like this high propensity, this high risk for temper outbursts, a tendency to repetitive and ritualistic behaviors or obsessive type behaviors. For some people, the problem of skin picking, that particularly on existing spots or scars or whatever. So there's the issue of how we understand that. So there are those, if you like, behaviors that we know are common. But we also know that there are mental health problems that maybe underpin some of those behaviors, but not necessarily so. So anxiety perhaps triggered by a change in the environment, some unexpected change, is a major issue. People with Prader-Willi syndrome, as they get older, may have mood fluctuations from feeling low and depressed to at times being high, a bit like a bipolar disorder. We also know that people, particularly those with the disomy form, may be at risk in later life, in adolescence or early adult life, for more significant mental illness, sometimes referred to as a psychotic illness. I want to stress that whilst research has shown these are risks for people with Prader-Willi syndrome, we do actually have very good treatments for some of these, and the strategies and the medications and things that are available, providing the right understanding is there and the right diagnosis has been made, are really quite helpful and effective. But also we know that for some people with Prader-Willi syndrome, their developmental profile will be very similar to that of someone with autism. So some of the strategies that are helpful for autism may also be helpful for people with Prader-Willi syndrome. Now, by thinking about the mental health and behavior problems of people with Prader-Willi syndrome in this biopsychosocial and developmental way, it helps to focus research and research questions, and thereby, hopefully, new treatments in a very particular way. So if you think about the biology in the brain, what we now have is new neuroimaging, brain imaging techniques that allow us to interrogate certain things in the brain during someone's lifetime in a way that wasn't possible in the past. And certainly in Cambridge, people with Prader-Willi syndrome and their families have been just amazing in terms of lying in brain scanners for hours or answering questions for ages and so on and so forth. But we understand much more about the biological factors that lead to hyperphagia, for example. And new techniques are going to help us understand what is in the brain that might predispose to some of these other problems. But also, we know from work like from Chris Oliver's group in Birmingham and many others, and Kate Woodcock will be talking about some of her work on this, how some of these behaviors are shaped and triggered by factors in the environment. And we also know, as I mentioned earlier, about the importance of the environment and the social environment that people live in. Now, I hope that just gives you a very brief introduction to how we, I think, both as clinicians and as researchers, have over some years now been thinking about these mental health and behavior problems. I want to, however difficult they are, I do want to paint a more positive picture about them, because we hear from questionnaires and interviews that these problems are absolutely on the top of your list that need to be resolved. Now, I think we have a much better understanding. I think the difficulty is that, of course, the interventions require sometimes hard work over days, that there isn't usually an easy intervention. But there are interventions, and I think later in the day, Linda and Janice will be talking much more about those interventions that can reduce the risk for, say, temper outbursts, but also help you manage them when they do occur. So what I'd like to do now is really invite the first speaker just to come and say a few introductory points, then we'll be sort of all sitting up here in the end for the questions and answers. So maybe Hubert, wherever you are, I can't see. Hubert, do you want to come and start the process off?
Yes, welcome all together. A little bit to introduce myself. I'm from Germany, and I think you already know about my accent in English. And I'm from a big company that has services for disabled people and for about 7,000 disabled people. And I'm the director of a part of them. And we started to have services for people with Prader-Willi syndrome 1995. And since this time, I'm infected with this. And I think that's the reason why I'm standing here after that long time. And yesterday, I was so impressed about Megan, and I thought about, yes, that's the reason we have to look on the rights of the people with disabilities, and it's a focus I want to, and it's a big focus to get health, I think. For each treatment and each support, I think, of persons with Prader-Willi syndrome has to be based on attitudinal and environmental structures, as Tony already says, with the focus not only on the symptoms, but also on the person as a unique individual. And I think, therefore, we have the Convention of Rights on the rights of persons with disabilities. And I remember it was also a lady from Canada. She was a High Commissioner of the UN, and she told about the convention, and she was nearby. She also worked in Osguthol. It's close to this hotel, I know. And she said, it was Louise Arbour, and she said, the convention marks a historic step in ensuring that persons with disabilities enjoy full participation in society and can contribute to the community to their full potential. And I think really about 130 countries all over the world have had ratificated this convention now. And that's important for me, and that's a challenge for the future, how to make it vivid, this convention. And therefore, now persons with disabilities and also persons, of course, with PWS are not viewed as objects of charity, medical treatment, and social protection, rather as objects with rights who are capable to claiming those rights and making decisions for their lives based on their free and informed consent, as well as being active members of society. And yesterday, this was the best example we could have when we heard the speech of Megan. I think for me there are three questions. How can we support people with Prader-Willi syndrome to get these rights? Is it possible for people with Prader-Willi syndrome to reach full participation and inclusion in society? Do we have the phenomenon of heterogeneity in face of Prader-Willi syndrome? These are big questions, and I don't have the answers. But I think it's necessary to strengthen, to find these answers. And if I look only on affect control, I can tell you about, yes, you know all about temper tantrums, ritualistic behavior, strong mood changes, compulsive and rigid behavior, stubbornness, obsessive behavior. You all met it, and I know this is the biggest challenge often which parents and caregivers have. And we made a short, have some statistical dates about, in our institution, about 50 persons with Prader-Willi syndrome. And it seems they have a heightened predisposition for psychotic symptoms and psychotic episodes, especially in UPD. And therefore, we looked at the numbers of inpatient stays in psychiatry, and we have a group of 53 people with Prader-Willi syndrome. 22 did not have any stays in psychiatric treatment. 11 people had one, 8 people had 2, 7 people had 3, 2 people 4, a lot of numbers, and 2 people had 5 stays, and 1 person even had 7 hospital stays for inpatient psychiatric treatment. I find it interesting that only 11, that are 15%, of these inpatient psychiatric stays were necessary at our facility after the patient's admittance. 62, that's 85% of all psychiatric stays appeared in circumstances that exhibit structures that are not PWS specific. And if we break down the total number of inpatient psychiatric stays, in those that took place before and after the patient started living in a specific setting, we can assume that stresses in the living and work environments play an important role in the onset of symptoms that requires psychiatric statement. Yes, that's only a short look upon, and for me, I think it's necessary, in conclusion, the disabilities suffered by persons with Prader-Willi syndrome are partly the result of the way in which society chooses to interact with them and shapes the environment in which they are expected to live. Thus, the lives of people with Prader-Willi syndrome can often be improved considerably by normalizing these contacts and fostering positive attitudes towards them as well as meaningful relationships with them. At the same time, I think it's important not to disregard the particular needs of persons with Prader-Willi syndrome. A thorough understanding of the genetic, medical, psychological, and social causes of PWS is imperative to facilitate targeted and effective interventions. Provided caregivers do not all to embed these treatments into holistic and community-based care plans. And I think, for me, it's really necessary that we have an approach that is not monodisciplinary, that's not interdisciplinary. It must be a multidisciplinary approach to help them. And therefore, we need all the research, but we need also the parents, and we need the caregivers to work together. And that's, I think, it's the best way to keep our people with Prader-Willi syndrome healthy. Thank you.
Thank you very much, Hubert. And now if I could ask Elizabeth Roof, where's Elizabeth? There.
Hi, I'm Elizabeth Rue from the Vanderbilt Kennedy Center, and I'm really pleased to be part of this panel today because I think mental health issues are a huge issue in PWS. And where Tanya said we have a lot of experts, I feel like for most of you, you feel like you're in the desert most days. You're like, I don't know, somebody told me this. And so we're going to talk a little bit about what my background is, what our research has kind of shown. And then whenever the panel is open for questions, we'll talk about what kinds of things you guys want to know about. So I actually am at Vanderbilt Kennedy Center. I've worked with people with Prader-Willi syndrome for 21 years now, and we follow about 300 people with Prader-Willi syndrome all over the country, and quite a few from Canada, and we're really interested in teens and adults. And when Hubert was speaking about, the fact that we all have to work together, we so have to work together to provide an environment that's good and safe and works well for them. I'm actually a former teacher. I did that for several years, went back to school, and my biggest claim to fame is I have 2 teenagers, so trust me, I know what oppositional and defiant behavior looks like. So what we do at the Vanderbilt Kennedy Center is I work with Elizabeth Dykins. We've been really interested in compulsive behavior and kind of rigid behavior. We published quite a few journal articles on that, looking at what kinds of things are really common in PWS. Our second grant looks specifically at some of the psychiatric features of Prader-Willi syndrome, and actually in the next probably couple of months, there's going to be several articles coming out about autism features in Prader-Willi syndrome, psychiatric features in Prader-Willi syndrome, and kind of what we know. And so one thing I will say is that, just like Tony said, is the language, the things that we say and the things that we do sometimes don't really match up, and a lot of people that we see get all these kind of diagnoses, and people are treating all these things, and nobody's really talking sometimes about the same features or the same symptoms. So for us, it's about finding ways to communicate effectively among professionals so that we're talking about the same thing, we're treating the same thing. And for us, we're really interested in how some of those odd social features that a lot of people notice in their kids. And it was great when Teresa showed some slides yesterday about parents, sometimes their top 5 concerns are about social concerns. My kid doesn't seem to have friends, my kid doesn't seem to get along with other people, all those things are their real concerns for families. So what we're really interested in is figuring about how those things, how not connecting or being socially isolated or withdrawn can lead to a lot of psychiatric features. And the one thing that's going to be coming out very soon is we've been following so many people for so many years, and we have all this data about what meds they're on, what symptoms they're exhibiting, kind of where they're located. Are they at home? Are they at school? Are they living in a group home? What kinds of things are actually helpful and what kinds of things are not? And one thing I will say is the psychotic features and the depression that we sometimes see with people with Prader-Willi syndrome, especially the ones who are higher functioning and seem to really kind of get that they're different from other people, we know that being socially isolated and withdrawn is a huge risk factor. And I'll actually be talking a little bit more about that in the adulthood thing later this morning. But one thing we know is that when they're isolated and disconnected, they're more likely to suffer from psychosis and depression and anxiety. And when Hubert said, like, not having anything to do and not having rich environments for them to actually kind of function in, A lot of families kind of think, well, you know, he's off in his room and he's playing and he seems to be okay, until suddenly he's not. So what we want to do, and we actually just wrote a grant for this, we're going to use virtual reality to actually create social groups for teens and adults with Prader-Willi syndrome so that we can teach social skills, connectiveness, give them a sense of community, and find a way to actually help people with Prader-Willi syndrome connect. Because I live in a state of, Tennessee, and so we have like maybe 50 families that I know of really well. But the deal is, it's so hard for them to get together. And we've done several drug studies where we see people week after week and month after month, and we laugh because they're so excited. They're like, do I get to see other people with Prader-Willi syndrome today? And they're just waiting for their time to go to somebody else's room. They get there, and what do? They stand against the door and they go. So we want to find a way for them to initiate social contact, find a way to make friends, keep friends, and learn some of those social skills. And one thing we often notice, and you guys who all have children with Prader-Willi syndrome know this, they often take the world as kind of a negative and threatening place. So, whereas we see things happen, the weather changes so you can't go do this or you can't do that because schedule changes, they're like, what? The schedule's changing? I can't believe this. They're so inflexible. And with social interactions, they often do the same thing. They often want people to say things a certain way. They want them to go a certain way. I always say it's like a movie script. Wait a minute, turn to page 7. Halfway down, that's what you're going to say to me next. And then I'll say this, and then you'll say that. They have this real idea that they want things to go a certain way. So what we want to do is find a way for them to kind of understand that there are things that are appropriate and good social cues and good things to learn. And we want them to actually start to look at people's faces, because one thing we've been looking at ERP and EEG data, they don't look at the right place. So, we look at people's eyes to kind of know how they're feeling, and people may smile at us, but their eyes say, I'm dead up here. So we kind of know what's going on. People with Prader-Willi syndrome, they look at the oddest places on people's faces, so they don't ever read a lot of the social cues that we see. So we want to teach them ways to do that, ways to interact, and ways to connect meaningfully and socially with other people with Prader-Willi syndrome. We're going to actually have we're going to have facilitators as part of these virtual reality groups to show kind of how we mediate conflict, how we deal with asking people about themselves. People with Prader-Willi syndrome will ask a couple of scripted or kind of repetitive questions about other people. What did you have for dinner last night? How much did you eat? Were you still hungry? They have a lot of questions they want to ask, or they'll ask about something they're interested in, like, do you have a dog? What's your dog's name? And they'll kind of go on that same vein where they kind of talk about something over and over. We want to teach them that asking people about themselves and finding out about people is a really important way to connect socially. And if you don't find out about people, you're not going to be able to connect meaningfully. So we want to teach them some of those social skills. It'll be over a period of 8 to 10 weeks where we'll be building on it. They'll have 3 times a week sessions online, and we'll follow up with people, and we're going to include parents in part of that as well. And then we're going to find a way to measure that out in the community settings, because for a lot of people, they talk about we have this intervention and that intervention. We want to find a way that it actually kind of spreads and generalizes to other settings, because I tell people, I could be really social online. There are lots of people who are like that. And then they go out and they just stand there and they have no ability to generalize it. So we want to find ways to actually film them when they're interacting with other people. Do they have eye contact? Do they look at the right place? Do they ask questions? Do they respond appropriately? We want to find ways to measure that, because we really feel it's important to be able to find ways to have them connect. And if we do that, we feel really strongly that we can actually mitigate some of the depression, some of the anxiety as people get older. Once people leave school, there's so little options for them to connect. And I have, the last few weeks, had lots of people who've told me how they feel so lonely, they have no friends. They want to find a way to be a part of society, and I think we really have to find a way to make that happen as much as we can in a way that's safe and secure, but also gives them opportunity to be a part of our world. And I think when Hubert said that, it's really important for us to make a world that's safe for them so that they can actually do that. Because for so many of the people I see with Prader-Willi syndrome, they often tell me, I want to have a normal life. That may not be the same thing as my normal life, but it should be as normal as we can make it for them and as safe as we can make it for them. And like I said, so many of them want social connection. So again, I'll be talking a little bit later about adulthood, but I'll be glad to answer any questions when we finish this panel. Thank you.
Thank you, Elizabeth. And now the third speaker, Kate Woodcock. Who's Kate? There we are, Kate.
Hiya.
So since I don't have the years and years of experience of everyone else on the panel, I have got some slides. So I'm going to focus on talking a little bit about our research that looks at really the difficulties with change that many individuals with PWS can experience. So I am going to start off by talking about what those difficulties are, but importantly I want to focus on how we can use our understanding of those difficulties to develop ways to help reduce them. So these are some examples from more than 50 interviews I did, probably more than 10 years ago now actually, with the parents and caregivers of children with PWS. And what came out of those interviews was really the very strong preference for routine and resistance to change that individuals can show. But importantly, when things change to individuals' routines or plans or expectations, that's when we can see elevation of upset, or some people call it anxiety, and potentially temper outbursts. So basically, change is a very common trigger of temper outbursts. So that's important because if we can say, yes, just change on its own has an important role in temper outbursts, then if we can work out ways to tackle just the change, then that should help us to lessen that difficult behaviour. But if you look up on this slide, what was important from the interviews is that several of the examples that parents gave us, yes, we see a change, but we also see other things going on. So, for example, the woman who said that her child had to have a packet of sweets for the journey home from her granny's because that was part of the routine, and if she didn't get that packet of sweets, then there was trouble. Obviously, we do have a change to routine if the girl didn't get the packet of sweets, but of course, we've also got something else going on there and something very important. So what we wanted to do then in more controlled research is to try to isolate just what's going on with the change. So what's the role of the change on its own? So in a minute, I'm going to play you a video. And in this video, basically what we did was play games with children. And sometimes we would follow the routines or expectations of the child as they were expecting. But then at other times, we'd make sneaky little changes to those routines or expectations. And importantly, watch what happens to behaviour. So do the behaviours that we typically see during temper outbursts, like arguing and raising the voice, refusing requests, asking a lot of questions, do those behaviours increase just when we make changes? So I'm going to play the video now.
No, you got to keep blue and green. That's what we got.
I'll give you a red one.
No.
A green one.
No.
Why not?
You should have that.
Okay. So, hang on, I'll move it on. so that's really important because it tells us that just the change can precipitate these sorts of low-level temper outburst behaviours. But of course, we don't know from that information how much of a role just the change on its own has in a full temper outburst. And so that's why we really needed to observe children in their everyday environments to try to isolate just the role of change on its own. So I'm going to show you a video of that. I've been here for a long time, Becky, and I'm going to come back. I'm going to come back in time. It's all right. We've got lots of time, and I'm going to come and visit you again. Come on, we've got to go. We've got to go. Come on. Come on. Oh, you want the other one? I wasn't. Yes, Becky, honestly.
You get out of my house and go away.
So, of course, it's horrible to have for me to have to observe that behaviour, but I know you guys appreciate it. The critical point there is that Becky's temper outbursts that she had on both occasions, which were quite far apart, like several weeks in between, they looked almost exactly the same. But what was important is that the change in her expectation was completely opposite. So the first time she was expecting to play games with me, but then she was told she couldn't. And the second time she was expecting to play games with me up to a certain point. And then I said, could we just do an extra 5-minute game? So we were controlling for the other things going on and isolating the change and showing that just the change on its own could precipitate the temper outburst. And that's important because it suggests that if we can find a way to tackle changes and potentially make changes more predictable, then that could have a beneficial effect on behaviour. So I want to do an example of how one of our strategies that we're using to try to address change works. So what I'm going to do is play some quite horrible loud noises. So if you've got sensitive hearing, you might want to cover your ears. Okay, so was anyone expecting to hear the sound that last time? Yeah, so because I showed you the noise sign and then you heard the noise, you should have learned an association between seeing that yellow noise sign and the fact that a horrible noise is coming up. And so that's why then when I didn't play the noise on the last time, you may have felt a bit surprised. But importantly, it's also why hopefully the second time I played the noise, it may have not been quite so bad because you should have sort of been preparing yourself a little bit for what the noise sounds like and had a little bit more time to prepare. And that's just after just one warning. So basically what our change signalling strategy does is it uses a similar principle, and it's led by parents and caregivers, and we teach them how to use a distinctive signal card along with a standard verbal phrase so that whenever the parents or caregivers have prior warning that something's going to change, they can use the signal to warn the child and hopefully make that change itself more predictable. And so we've tested this in a small group of children, some adults with PWS. And importantly, what we've shown is that if we look at temper outbursts behaviours following a change that's been signalled, we get less difficult behaviour than if we look at a change, the same change that hasn't been signalled. So what we're doing now is a much larger evaluation that several families with children with PWS are taking part in, and we're comparing this change signalling strategy to another approach that uses visual scheduling to try to plan ahead in a way that will reduce the number of changes that are likely to provoke anxiety or temper outburst behaviours. So it's two different ways of dealing with change, and we're comparing how they both work. And you've got some more information on like ongoing comments in the slides that are on your USB sticks, but I'm not going to go into those now because it's still an ongoing evaluation. But why then do individuals experience difficulty with change? It seems that a cognitive or brain process called task switching may be really important here. So task switching is basically changing how you're thinking about, changing from thinking about something in one way to thinking about the same thing in a different way. And the example that I've used a lot, but I think works quite well, is if you think about eating a hard-boiled egg and you've got a spoon, and so you start off by trying to open the egg with the spoon. So you have to think about the spoon as a sort of heavy-ish, hammer-like implement to crack open the egg. But then if you want to eat the egg, you have to change how you're thinking about that spoon, and instead think about it as like a concave type implement that's capable of scooping out the yolk from the egg. So it's that flexibility in thinking that task switching is. So our work and others have shown that PWS may be associated with specific difficulties with task switching, but importantly what we've found is that individuals that have more difficulty in task switching also have more resistance to change. And that suggests then that perhaps if we can improve task switching, we could reduce resistance to change and reduce temper outbursts that follow changes. So I just want to show you one more video, and this is where we were just changing the cool cognitive demands on task switching, and we're still watching what happened to behaviours, and particularly those temper outburst behaviours that I've talked about. So can we play that video?
Car.
In a country with no children with eggs.
It said no car. No, it said no the car. It said no the car.
So we saw more questioning, arguing, the same sorts of behaviours when we put demands on task switching. And so that suggests that if we could improve task switching, maybe we'll see a benefit in less resistance to change, less temper outbursts that follow change. And so one of the things that we're doing at the moment is developing a video game specifically tailored for the needs of children with PWS at the moment, to try to improve task switching. And I talked about this in the scientific conference, and I know many of you were there, so I'm not going to go into it in too much detail here, but there is more information on the USB stick. But ultimately, the key thing here is that we worked with children with PWS collaboratively to try to make the game really, really motivating. And it's not quite motivating enough yet, but even in the initial prototype stage, we've shown in a controlled study, it's a small study, but it is a controlled study, we showed that the game seems to be capable of improving cognitive task switching. Now, that's just after a short period of play between 1 and 4 hours. It doesn't mean to say that we've shown that this game has an effect on behaviour, but it's really positive evidence to start off with to suggest that if we can develop this game better, it may in future have a beneficial effect on behaviour, and we've got plans about how to do that. So I just want to end with thinking a little bit about whether how we may be able to help task switching develop better during childhood. And this really started with the interviews that I mentioned right at the beginning, where not very many, but a few families happened to report to us that their children really had never had any difficulties with change. And we just noticed that those families also happened to be those that told us things about flexibility. So things like, oh, well, we've never really been good at having a lot of routines in the family, so so-and-so has really had to get used to dealing with a bit of flexibility. And so that set us thinking, really, because if we look at how task switching develops in typical children, we know that one of the ways that the environment can affect that is that if we get more flexibility in routines, that may facilitate the development of task switching. So we really want to look at this a bit more. And this was just in a very small study, so we're still talking preliminary evidence, really. One really important thing that we noted is that for any individual right now, which is consistent with everything I've said so far, any individual right now that does already have a resistance to change, by having rigidity in routines or a lot of structure in routines, that can help to minimize the experience of anxiety and minimize difficult behaviors that might follow change. So we know that. And so that's an important thing that we definitely need to try to do. But the other really important finding that we found from, again, this small study, but nevertheless, it's interesting because we found that parents reported to us that if their child had more rigidity in routines whilst they were in primary school years, which for us is between about 4 and 11 years, at some point during that period, if children had more rigidity, then later on, those happened to be the children that were showing more resistance to change. So that doesn't suggest that one thing causes the other, but what it does suggest is that if we could work out a way to have the overall structure that we know is beneficial for individuals, but also implement a level of flexibility that's enough to get the benefits that we might see on better development of task switching, then that would be a potentially really good thing to do. So one of the things that we'd really like to do in future is to track children over time, look at how their task switching develops, how their resistance to change develops, and what sort of routines they have. Are they flexible? Are they rigid? And work collaboratively with parents, for example, with parents who already try to implement some sort of flexibility and the success or not so much success that they've had, and try to work out how to best advise families to have this sort of overall structure that's enough to minimize anxiety and difficult behavior, but have flexibility built in there, which might be beneficial for the long term. So that's where I'd like to end, and this is just a thank you. So FPWR supported some of this research, the cognitive switching training game, and then there's many other funders and several people from my team that have contributed also. Their names are there. So thank you very much.
Thank you very much, Kate. Before I invite Linda and Janice to join us, I'd just like to sort of try and summarize by trying to make the point that when we talk about mental health and behavior problems that affect people with Prader-Willi syndrome, just to remind you, we have to think about them at these different levels. And I think each of these talks has in a way illustrated that. You know, there is the level, if you like, of what one might see as almost human rights. It's how do you, as Hubert was talking about, how do you balance the fact that you want this person with Prader-Willi syndrome to have a good, normal life, but against at the same time, the problems that you know that they have to face, whether it's the eating, the tempers, the poor sociability, and so on. There's a tension there that we need to address. But also we've talked about the environments that people live in, the opportunities that they have, and how you can help them develop new ways of engaging socially. And really this was Elizabeth's point that so many people with Prader-Willi syndrome seem to want this, but when it actually comes to doing it, it's much more problematic. And thirdly, I want to make the point that I think is very well illustrated by Kate's presentation, and that is from a more research perspective. What we're trying to do is to understand the mechanisms that underpin each of these problems, and they're going to be rather different. So when we talk about the temper outbursts, then the work of Kate illustrates the importance of task switching, or the inability or the problems of task switching, and so on. When it comes to understanding the mental health issues, the risk of psychotic illness, the underlying mechanisms are going to be rather different. But by understanding the mechanisms through research, which will be observation, questionnaires, imaging, all those sorts of things, and most importantly, the willingness of people with Prader-Willi syndrome to take part, because without that, this research cannot be done. But this research then identifies the mechanisms, and you can see, listening to Kate's presentation, how, as one understands, in this case, the temper outbursts, it's almost obvious what needs to be done. The interventions themselves aren't necessarily always the challenge. It's the understanding in the first place, and then the interventions follow. But I want you to think that the mechanisms that underpin each of these things may be rather different. So what works for temper outbursts will be different than what you need to do in terms of someone who may have developed a mental illness. So maybe Janice and Linda, if you'd like to join us up here. We've got 2 chairs there. Thank you. And we really want to open it up to you for your comments, for your individual experiences. And I'm sure in this audience you won't feel shy about talking about the difficulties that you've had or the successes that you've had. And so often in conferences we hear really interesting sort of tidbits about how you've managed something that really help us think about these things as well. So over to you. And I don't know if we got a microphone, but yes, we have. Right, Keegan's got a microphone here.
Phone that works. There we go. All right, we'll start right here. Raise your hand. I will eventually get to you.
Okay, I wanted to talk about something that Elizabeth said earlier about the social aspects, and one of the things that I find interesting is, so a lot of people think that our kids are so social, which they are in that sort of initial meeting, but then it doesn't go deeper. We're trying to teach my son to have a deeper conversation that goes not toward where he wants it to go, but where maybe somebody else, and it's an ongoing process and we're not there. But one of the things that occurred to me, he's 10, and some of his focus is kind of okay when you're 6, 7, 8, 9, 10. He likes lawnmowers, he likes snow plows, this is a supreme interest for him. And it's not something anybody else wants to discuss, really, particularly when he gets older. So I also see people like Dante and other people who are really into sports. This is something in the real world you can get people to go listen to, also music, also things like that. So I wonder about gearing our kids towards things, if they would have to have some level of interest. Obviously, if my kid's not interested in sports, he's not going to care about sports, but maybe he likes music. And so finding subjects that they are interested in, but are socially acceptable to have long, in-depth conversation, you know what I mean? Right. Where people will listen to them because they are equally interested, that kind of thing. I wondered what you felt about that.
Is it on? Okay. So, I think with Alexi, I think that's a really good point, that a lot of kids have kind of restricted interest, and I do think there's some overlap with some of the autism restricted interest things. So I tell people some of it is just kind of getting them to understand what I may be interested in is not maybe what someone else is. So sometimes it is good, and I would agree, and I tell people this, sports, music, they're always or popular culture are like the 3 things that some people know something about. So you can throw that ball out there and see if somebody throws it back to you. So this idea that we teach our kids that these are things that most people are interested in. And it could be scripted, it doesn't really matter. You come up with a sentence like, what kind of music do you like to listen to? Somebody could talk for hours about that. So you teach them basic skills so that, like you said, things are not superficial anymore. And that's really where they struggle. I can smile at you and look really sweet. Once you become an adult, that doesn't really cut it, does it? So it's this idea that we need to find them ways to teach them skills that are like transferable in the real world. And it's okay if it's scripted initially. The thing is you start there and you hope to kind of make them more flexible. And when Kate was talking about flexibility, that's really what they lack. This is what I like. I can't appreciate what you're interested in.
Is there any comments? Yeah.
I just have to share a story, Elizabeth, when you talked about the socialization issues. A classic scenario is many years ago at a PWSA USA conference, our son and daughter were doing a little workshop for those with Prader-Willi on socialization and sexuality. And our son said to a young man, now you're going up for your first date and you go in the door and you knock on the door. What is the first thing you say when they open the door, when the girl opens the door? And he said, you ask them, do you have AIDS? So I just think that's a classic example of, yes, that's an important issue, but maybe not how you start.
You might not want to start with that.
Thank you, that's a wonderful example.
Hi. Could you address the insistence of eye contact? And my son's 20. After 20 years of saying, could you look in the eye? Can I stop? Because he's not going to look anyone in the eye. And I'm so tired of telling him to look people in the eye and people expecting him to look them in the eye. And I don't think he's capable. I went to a conference in Orlando, and there was something about the eye and research about that. Could you address that?
Yes.
I mean, you're right. So I tell people, like, you know, reminding them over and over about certain things are really hard. And when you get to be 20, a lot of that's definitely pretty ingrained at that point. A lot of them are really uncomfortable with eye contact. So I say if you can look in the general eye, area, ear, top of the head, something in that general area. And as long as you can teach them some skills where they can actually continue to reciprocate socially, then that's okay. There are a lot of typical people that are very uncomfortable. I know I'm working with more and more people who are in their late teens and early 20s who don't have Prader-Willi syndrome. And because they're looking at their phone all day, they really have a hard time looking at people in the eye. So I would say that it's okay. I would not keep reminding them because at some point it's sometimes really uncomfortable for them. So if they're just generally engaged, people can deal with that, I think.
Linda, do you have?
I wanted to reinforce that also. One of my own patients came in on the autistic spectrum and said, well, I just picture a dot right here, and I find out that if I look right there, it looks like I'm looking you in the eye, but I'm not. I've also asked my kids, and based on literature, and they will agree that looking people in the eye is uncomfortable for them, and that's why they avoid it. And the third thing I sometimes say is you can really get a lot of mileage out of just looking at someone briefly in the eye and then looking away and finishing your sentence and then a quick glance. And so for some higher functioning people of that sense of timing, they can get away with that. But I agree with you, badgering him on it is not fair because you're asking him to do something that's uncomfortable. I think acknowledging that it's uncomfortable and maybe at least trying some of those strategies, if they don't work, leave them alone.
I had to say, whilst you were speaking, I had an image that instead of a dot, it was a piece of food. Do you think that might make a difference?
So I just want to add a little bit of a different perspective to this because I think neurophysiological studies suggest that individuals with Prader-Willi syndrome have difficulty with multimodality processing. So they're really not unilateral, but they process one modality well at a time. And when things become more complex, they have more difficulties. So I think I've thought about this issue of the difference between listening and looking. And I think that it's very difficult for our guys to do both at the same time.
Yes, it's our experience too, and I want to add, it's not only listening, it's listening and hearing are different too.
Yeah, yes.
And therefore, sometimes it's helpful, we know it from people with autism, to work with a mirror. For they had to consider themselves sometimes, and they don't know what happens, and it's often helpful to work with a mirror in front of a mirror.
Right. Yes, that's
I have a friend, Phyllis, she's here today, and we were discussing how do you describe PWS to other families or friends? And she said, it's like autism on steroids. And it's really true because we have all the challenges of autism, but we have, the challenges of obesity and so many other things. But one of the benefits with autism is that there's a lot of funding, there's a lot of programming, social skills, things like that. But we can't access that because we don't have a diagnosis. And what I have been asking professionals to look at my daughter with PWS, she's 10, and are there any signs? And I see a lot of signs. She doesn't interact with peers, she doesn't know how to, interact, start conversations, things like that. And yet the community's sort of saying, well, she has PWS, that goes with PWS. And there's no way of teasing out the autism piece and getting recognition and funding for those things. So my question is, how do you tease out the autism piece? Because some of our kids are so good at understanding other people, especially adults, and manipulating them and having them wound around their finger. How could that be autism? So that's my question to you.
Janice, do you want to go?
I'll address one part of that. Part of the problem is just describing Prader-Willi syndrome in a concise way that's useful. So when I have only 10 minutes on the phone with a physician, or if I'm doing a training, I don't open with the food issues at all. The first thing I tell them is, this is the most stress-sensitive individual you will ever encounter in your career. And that's how I lay the groundwork, because people often miss that most of the subsequent issues have to do with that stress sensitivity that Kate described so well. So that's one part. Teasing out what's autism and what isn't. You want to address that?
You're doing that, right? Yeah. So I'm going to talk about that in a little bit, but we actually have a new study that's just coming out, a publication about that. So PWS is difficult. If you look at a lot of the research that's been done, it's on questionnaires. And so if you ask parents what their kids do, about 40% of people would meet criteria for autism, and so that's what people have been doing. That's not the best way to diagnose autism. It's a little bit like those mental health screeners you see in the back of a magazine. You're like, oh my God, I have this. So I tell people it's really important to actually see a clinician if you think your child has autism. There are some questionnaires that need to be done. There's a full family background, social, and kind of like cognitive history that needs to be done. And then somebody does something called an ADOS, which is a diagnostic interview with the person. And I've done about 300 of those. What's so interesting to me is even though they have a lot of features of autism, they don't really meet criteria for autism. So we have a lot of people who actually, after I do this and I score it, they come and watch it as well, and they often go, they got autism. I said, well, if you know all these things, what do you think? And they said, no, definitely don't have it. So I would say that if you can get that diagnosis, it's definitely occurs. It's about 12%, it's not 40%, that actually have autism. But if you can do that, you can get services. So I tell people, do what you need to through your school system to actually have that done if you think that's something that she would benefit from. And I will say that kids with PWS and autism benefit greatly from social skills groups, from some ABA kinds of therapy in the home and school. I've seen some huge changes in people socially by doing those things early on. And if she's 10, she's at a critical point. You wait too much later, you're not going to make a lot of difference at that point.
There's no question, there's no question that meeting criteria for the other diagnosis, autism, in addition to Prader-Willi syndrome personality, which all of our guys have, really does access services, and those services really provide a more enriching environment for our guys and really do help them with skills acquisition that I think are really essential during a specific phase during development. But I've struggled with this also because, and I'm glad to hear that you're actually looking at this in an empirical way. I think that there are a lot of characteristics of autism that are shared with Prader-Willi syndrome, sort of like a big Venn diagram. But autism is a very heterogeneous disorder, and it comes from many different etiologies. But if we can take advantage of those individuals who do meet both, then they can get more skills, more help.
I mean, I think one of the interesting things that comes out from being involved with an organization such as IPWSO is you have the opportunity to hear about different health systems. And I think for you in the States, that is a very major issue because things are compartmentalized and insurance-based. For some of us, that's less of an issue, I think. There is, in the UK, there's an issue of resources, but less of an issue about whether you absolutely meet certain criteria in order to get those resources. So it does vary across countries. Yes.
Hi, my name is Cassia Johnson. I'm Keegan's little sister. It's my claim to fame and Dante's auntie. But I'm also a developmental pediatrician in Hamilton, just down the road. Hello, fellow person up there. I have a question for the panel and something that I've been thinking on, and obviously being a family member, think on it often. And I run a general development clinic, so see kids with all sorts of diagnoses. Autism, which is just a description of behaviors, doesn't carry a diagnosis, a genetic diagnosis, but I see anxiety, I see inflexible thinking, I see hyperphagic behaviors, I see skin picking. Clinic often ends up with meltdowns and people standing by doors. But in that thinking, my question is, and I sit in a room where everyone is concerned about one diagnosis, but I wonder about, do we have, and I've heard you mention, do we have statistics of whether there are certain features that are more prevalent in PWS? Because it leads us to the next thought of who's doing what, where, and other places. There's facial recognition programs and work it's huge in the autism. There's social skills training. There's psychosis work in the Down syndrome. So I can go through a number of other specific diagnoses and talk about programs and services that I hear people bringing up. So my question to you is, what are the numbers that make these things more specific to PWS? And if those numbers are there or are they not there, I challenge the group to understand and to think about where else these programs already exist and what you can use.
Who wants to address that?
That was a complex question.
Yeah, it is. I mean, just to say, I wasn't quite, when you talk about numbers, I mean, are you saying what percentage of people with Prader-Willi syndrome have these particular
I hear
problems?
everyone say like they're more anxious, they're autism
Yes.
on steroids. From clinical experience,
Yes.
my clinic's autism on steroids. My clinic is Down syndrome on steroids. My clinic is CP on steroids, literally and figuratively.
Yes.
So if any of these specific things are more, because they've all got genetic underpinnings
Right.
that cause all these diagnoses.
I think that's a very important point. I mean, certainly in the population-based study we did in the UK, in which we tried to identify everyone with Prader-Willi syndrome in one particular area. So it wasn't clinic-based, because obviously if you do any study that's clinic-based, you have a very selected population. But there, I think by and large you can say that hyperphagia, but to varying degrees, is almost universal, if not universal, among people with Prader-Willi syndrome. Temper outbursts, the sort of figures that are often given, that this is a propensity, a marked propensity to temper outbursts, will be in the order of 60 or 80%.
More so than other diagnoses?
Well, that's if yes. So what many of these studies have done have had a control group, so a comparison group of people with similar intellectual disabilities, but not due to Prader-Willi syndrome. So I think there is good evidence from many studies from many different countries that support the idea that there is a cluster of problems that seem to be, they're clearly not unique to, but they are particularly common in people with Prader-Willi syndrome, and they cannot be explained readily by, for example, any intellectual impairment that they might have.
You're a rare disorder with not as much money as...
There are absolutely...
Go for the big ones.
Yeah. Do you want to add?
Yes,
Yes,
sorry, can I just add? So I think, like when we're talking about autism, obviously it's important to remember that we don't know what causes autism. We do know what causes Prader-Willi syndrome, but there's a lot of variation in across all individuals with autism, just as there is variation. So even though
Yes.
60 to 80% of individuals with PWS have temper outbursts, that doesn't mean that every individual will have temper outbursts. And so I don't think, I mean, if we're looking at helping anybody, we need to look at them as an individual, and they may or may not
Yes.
have any individual one of these behaviours that we're talking about.
I think that's very important, and often what we're trying to do in research and clinical practice is to bring together what studies that have inevitably looked at groups of people tell us about Prader-Willi syndrome, and then apply that to an understanding of this individual who's in front of us now, and is trying to bring that body of knowledge together with an understanding of that individual. And that's the skill, as you know, of some clinical practice, really. Yes, Janice.
And then the other thing that I want to add to this is a developmental perspective. So across, with ages. Because I think that we all agree that we hope to find what those fundamental sort of skill deficits are that then are reflected in certain patterns of behavior. But then also with respect to anxiety, we know that there seems to be a time when the anxiety starts to rise, and all of us, will develop compensatory mechanisms, coping strategies, if you will, to deal with that anxiety to try to help ourselves feel better. And one wonders how much of what we see, across the differences in our individuals is reflecting in how they choose to cope with their anxiety. In the mental health workshop, there was a real robust discussion about the need to study anxiety in Prader-Willi syndrome. So I'm really looking forward to the next phase of our research inquiries to see if we can come to the root of what causes it, and then how it is manifested, and then how we might be able to intervene to help.
Yes.
At the clinical level, I think there's a lot of cross-fertilization that can go on. And if you are looking for services or looking for a physician who's going to be helpful to you, your best bet is a doctor who is already working with kids on the autistic spectrum. Because they understand the whole process of getting information from you and educating themselves about your child, because the behavioral syndrome is quite complex. A couple of things that have cross-fertilized in my mind: a good number of kids on the autistic spectrum are about as addicted to video games as our kids are to whatever it is that they enjoy. I've ended up using a no doubt, no hope, no disappointment paradigm for that, and it seems to work very well. Likewise, it was just occurred to me when someone raised those skills, those absent social skills after the first hello. I thought about my autistic spectrum girls, and unlike the boys, they can be very outgoing, but then things fall flat. They make friends, but they can't keep friends. So they can go several steps farther into the process, but they still have difficulty understanding what it is the other person wants to get out of the relationship. And so that's almost more parallel to our wonderful little social kids who are out there, but then they don't know what to do next. Just some thoughts.
Yeah. Next question.
Well, thank you everyone for your presentations. They were all amazing. My question is on a whole different topic, and is inspired on Kate's presentation about task switching. When you say that you find improvements on task switching on those families who are not the routine family group, did you also notice some kind of disorganized or chaotic behavior or difficult planning or anything like that on those kids of those families?
So I think there's definitely, so we know that being too disorganised is definitely not good. So that we know that from just typical childhood development, families that have a lot of disorganisation, that can have negative impact. But this is more just families that say things like, well, yes, we do have some sort of routine, but it's never exactly the same. Or, well, I have an intuition that always doing things in exactly the same way isn't a good thing, so I try and sort of mix things up a bit. It's that kind of thing. But I mean, that's only anecdotal in the interviews that we did, and then in this study where we systematically asked parents, that it seems to be repeated in that as well. Does that answer your question?
Yeah, thank you.
Who?
I think I'm on, yes. What you had to say about social skills and the need for friends. I think we also have to look at what our children view as friends, because in many cases they're very happy and satisfied with their perception of what a friend is. My 31-year-old has had a boyfriend for 4 years. His name is Richard. He has Down syndrome. They go to about 4 or 5 Disney movies a year. She's delighted. He calls her his honey bunny. They talk on the phone once a week. When we had a big 30th birthday party for my daughter, which could have gone one or both ways, but was actually a wonderful experience. He arrived a little late. She went racing across the lawn. Richard! They embraced and kissed, and everybody thought it was adorable. And then noticed the whole rest of the afternoon they ignored each other. They are happy. So we have to, as much as I agree with everything you're saying about social skills, we also have to look at the people involved and see if they are happy with the way they're interrelating. In Ontario, we have a Prader-Willi camp every year at Shadow Lake. Our kids know each other by name. They know details about each other. But I bet you they barely talk to each other while they're there, but they've had a fantastic time. They feel every year like they're at a family reunion. So I just am throwing that out there.
Your daughter's boyfriend sounds perfect. I mean, I'm like, yeah, sounds awesome. Here's the deal. There's a lot of variability in Prader-Willi syndrome. We have a fair number of people who, I say, who are your friends? And they, systematically name every kid in their classroom, and their parents go, like, what? So that's fine. Here's the deal, and I tell parents this a lot, and some people don't like to hear it. They're so concerned about their kids' social skills. They go, are they lonely? Are they unhappy? Did this seem to bother them? I'm like, no. I said, leave it alone. But we do have a fair number of people who do want social connection, and I will say that once you get out of school, which is the age that we're targeting in adults, being at home all day without structure is really isolating. Those are the people we're focused on. So yeah, no, I kind of tell people you have to, there's a lot of variability, so one size does not fit all. So if your daughter, and I have lots of people who say, I see my boyfriend once a year at the PWSA conference, sounds perfect, right? So my thought is it's all what makes you happy, but for some people they're very lonely and they say they have no friends or social connections. So it's finding ways to make that happen when they want it, not force it upon people.
So that's actually a perfect segue into what I was going to ask you about, which is the in-betweeners, the not little bitty kids, but they're not out of the house, they're not in a communal living situation. And what happens is, as you know, that little kids will just accept you the way that you are. But when you get to elementary school, junior high, high school, kids start to notice that your kid is different than them. And there are other things that interfere with their social skills as well. You know, you guys have talked about these other things, but the rapidity of adolescent speech, listen to the way we all speak, and then thinking about having a speech dyspraxia and not be able to join into a conversation, or the need for people to follow the rules, which quickly turns off other kids. They're like, you know, why is Olivia so worried that we all need to follow the rules? I don't get it. And what happens is, in the communities like I'm in, where we don't really have any other kids with Prader-Willi, I mean, we're kind of it. It's difficult to find situations where they can make friends, because Olivia is smart enough to know when she's accepted versus when she's liked, and she wants to be liked. So the question is, where do we look in our little community where we don't have other families with Prader-Willi that are near us, or maybe our kids are really different, to find groups, situations, people in the communities where our kids can actually make appropriate social connections outside of the Prader-Willi community. I find that very challenging because of the size of the community, and I'd like to hear your thoughts on where do we look for our kids to make friends that are that like them and don't just accept them?
Yes, I want to answer. I think that's really a big question, but it's always to try. We always try to make connections in the community. If it's some sport, if to do sport with others, to have a selection, to go to theater, to go to singing, to a singing group, or to serve in the church. That's really important for them, and to give them the opportunity to go without an assistance. And therefore we have to train the others to take care of the needs they may have. And most of the time it functions, not always. We know they are really sometimes, yes, it's nice to see how tricky they act and react and do and come to the things they need. Most of the time it's food, yes. But I think we heard yesterday from Megan say if they are really busy in the things they want to do, food is not so so hard for them to think about. And that's very important, to give them a lot of opportunities. And I think what's really necessary is they could make their own experience, not always the experience we have in mind. Right. And that's very important for them. And there are, I think, it must be in daily life and it must be in the community to people they know. There should have a big relationship. Is that was a little bit helpful in my answer for you? Yes. Really, inclusion would be that it's not important what you have. It's important what person you are.
But it is important to have something. I kind of say that if you're, completely typical, it's hard for them to connect. So I talk about friend shopping. It's like speed dating. You find people, you kind of see how it goes, and then if it doesn't work, you move on, and you just keep looking. But there are mental health groups. There are all sorts of groups that might be a really good fit for her. And some of the folks that I see who are high functioning, like Olivia's, they fit in well with people who have mental health issues, who have medical issues. That's where you go. It doesn't matter. It's just that they kind of get, oh, you have something different too. That's sometimes all that matters. But you have to really provide those opportunities. They do not come up on their own.
Okay.
In a rural community, sorry.
Go ahead.
She has
No, we've just got another question here, so if it.
Okay, quick question. I have a 6-year-old UPD, and when you're talking about all those mental issues, problems is a concern. So my question is what do you know in normal child development? Because what she's doing is she's role playing and she's talking to an imaginary friend, but at one point it's when does this become abnormal? Because she does it at home when she's playing, but sometimes she's at the park on the swing and she's talking to an imaginary friend. So at one point it's outside the home.
But that's developmentally appropriate, and I think we really have to think about where they are mentally. I have 40-year-olds who carry on baby dolls saying that they're their real babies. that's okay. And I tell people you can compartmentalize. So I tell people it's okay to do this at home, it's okay to do this here. So you have places and times that it's okay, but then you limit it, and that's a really appropriate way to be. What you don't want is them sitting in their school classroom talking to people who aren't there. So it's okay to have the imaginary friends, and I say they have to stay at home. Amazingly enough, kids with Prader-Willi are pretty good at that. Oh, okay, so Bob lives at home, so I can't take him with me to school. Yeah, that's how that works. So find ways to compartmentalize it so they're not doing it, but it's not inappropriate. And I don't want people to go, my kid's talking to people who aren't there. That's a normal kid behavior to have imaginary friends. Okay. So don't be freaked out about that. Just realize that there are places that are okay to do it, and there are places that it's not okay to do it.
And also when you do have it, because you're saying like UPD have more mental illness, is it kind of early sign that might be like oncoming problems?
No.
Okay, good.
No, don't worry about it.
Oh, I should stand? Sorry. Hi, I have a daughter, Claire, who's 9, and we've done a lot of social skills training, and in particular, self-regulation training. And we found a therapist who worked on zones of regulation, and I don't know if any of you are familiar with it, or if you've used it, or your success with it.
What is it?
It's talking about how we all have our own kind of level of anxiety or anxiousness, and as I am right now. But so it's like you're in green. Most of us are in green most of the time, and when I say most of us, maybe I'm meaning like typical. But then there's a lot of people who are walking around in yellow most of the time. And so when we see a meltdown, we expect that they should have been in green, but they've gone to red. And you're like, how have you gone from like here to here? And so talking about like maybe most individuals or some are in yellow most of the time, and really getting her to communicate and talk about, like, I'm at yellow, Mom, and I'm really close to red. Like, we need to do something here to help me get back to green, or, you know, and so just kind of doing that self-regulation on her own.
I think the idea that they tend to be, like I always call it a simmering pot, they're not ever cold, they're always simmering. So I think you have to kind of know that they're much closer to the edge, and that is the reason that the anxiety basically boils over. So what people see as, you know, unreasonable or really irrational behavior, it's not. It's because they've already been dealing with changes and trying to be flexible and all these things, so they're already close to the edge. It doesn't take much to boil over. I think if your child has insight about that, that's great. I think teaching them that, what I will say is when they get upset, it's like nobody's home, so it's hard for them sometimes to do something with it.
Yeah, it's
but
getting them before they get
yes,
Yeah.
try to at least understand it.
It's a really good program that they talk about
Microphone.
rock brain or a suplex.
Yeah.
There's these two little characters, and she'll even say,
Use the microphone, Sarah.
are you a rock head or are you going to be superflex? Right? And so it's just,
Oh, sorry.
I-
Kind of learning that people interact with you differently, and you have, because they have needs as well, that to help them get back to their comfort zone.
I
But
think
maybe
being
they're
aware of that is really
Yeah.
important. A lot of kids with Prader-Willi can't do that, but if your daughter can and it benefits, I just tell people, you try and you see what happens. There's so much variability, and there's so many really kind of unorthodox things that work well for them. So you just have to try it out. But if it doesn't work, you ditch it and you move on.
Sarah, I actually use the zones of regulation as well with Dante, and at his school, it's a really, really great program. Cassie, it's based out of St. Catharines, did you say? It's a Canadian program. Zones of regulation.
Yeah, we've had a lot of success with it. We were fortunate to meet a therapist who really took it on and then brought it into their school system as well.
So that's actually a perfect example of how we could take a program like that and maybe test it or investigate it with our PW population.
And teaching all children too.
Yes.
And so then they recognize like
And our husbands.
And a husband.
Yeah.
And they recognize like other people's zones. You know,
I'm delighted
Claire
to
sometimes would
hear
say,
husbands
like,
mentioned.
No.
Here. I'm delighted to hear husbands mentioned. I'm aware that it's 11, but Kate, you just wanted to say something.
Sorry, I just wanted to say one thing on that, because obviously it's brilliant if an individual themselves has that level of insight about the anxiety that they might be experiencing. But I think it's important to say that even individuals that don't have that level of insight, you can sometimes see in behaviours like those videos that I showed you, like parents are really good at being able to recognise, my son or daughter is fidgeting more, or they're looking slightly more flustered.
They're building up.
And that could then work with those sorts of strategies with individuals that are slightly less able as well.
So if I can now just, I know there are lots of people with other questions, but we will be around afterwards. So if I draw this session to a close and thank very much the speakers.
Wow, that was amazing. Thank you very much. The questions, the comments was very rich in discussion. Thank you everyone for participating and putting yourself out there, as Keegan said yesterday. So just want to give you a heads up on how the next session is going to work. So it is going to be a 30-minute session. If you are a Canadian, we would encourage you to come join us in the Civic Ballroom, Civic Ballroom South, if you're a Canadian, and hear up some exciting updates that we have for you. And then how to start your own organization. I've met a few people here today. I think it was Brazil. Where's Brazil? Very interested in starting their own organization. So that would be a great session for you to attend. And Dr. Cassidy, did you hear that? Okay. So, and anyone who's interested from a different country to learn more about it, even if you're not planning to do it, I think it's a great session to attend. And then another reminder that in the Kenora room, we still have our PWS registry sign up and information session. So please check out the Kenora room if you haven't done that. And then we'll see you back here at 11:30. So grab a coffee and join a session. Thank you. Thank you so much. That was excellent. I apologize.